So today, patient-centered care. We've got Esteban Peña, MD, care of the Hispanic patient with malignancies. Dr. Peña, welcome. So glad to have you here today.
Thank you so much for having me.
Yeah, absolutely. We've been looking forward to this, and this is our first time that we've done this topic, first time to have you here, so thank you so much.
Yeah, you have the perfect radio voice.
Oh, well, thank you.
I feel like I'm in NPR.
Well, that's very flattering. Thank you. So we've got information there, and our guests are welcome to read it, but we kind of pick out our top three, kind of David Letterman style. And Dr. Peña has 10 years of experience with managing patients undergoing bone marrow transplant. Impressive. And was able to practice medicine for a short period of time in Ecuador.
Yep.
Great. And performed quality improvement projects in the BMT unit, allowing for improvement in bone marrow, harvesting bone marrow biopsies, and other procedures.
Correct.
Great. And what's something we should know about you outside of your professional background, a hobby, an interest, something along those lines?
I love spending time with my kids.
Uh-huh.
I love woodworking.
Oh, my gosh.
Yeah.
Okay, me too.
And I love basically fixing cars, building stuff. So
Great.
I like being busy.
Okay, and that interest in cars, I think, is going to come into play in the first few slides here. So,
yes.
So that is great. All right, let's go ahead and move on to that poll everywhere question. Every patient is different. We make this first one kind of a softball. Most our past viewers know. So while true or false, while they're thinking about that, I'm going to do due diligence and put up our disclaimer. And now we'll take a look. Interesting. We're getting 100% true so far. How are they doing?
They're doing very well.
Great.
I don't think they need my lecture.
I think they need your lecture. I think it's going to get tougher than that.
Yeah.
All right. Care of the Hispanic patient with malignancies. Let me pass the
Thank you.
the keyboard and the mouse over to you and let you take it away from here.
And just the arrow key, right?
Yeah, just that right arrow key, and then if you need to go back to left, that should do it.
Okay. So I've been actually assigned to talk to you about Hispanic patients who have malignancies and how do we care for them. And since it's a very broad topic, I wanted to concentrate first on telling you a little bit about my personal experience, what I found in the medical literature, and kind of trying to connect those things and giving you ideas that, and for some people may be not that important, and for others they may be a great idea. So take what I say with a grain of salt, because yes, every patient is different, but there are similarities that we need to be aware of, and that's what I'm going to share with you today. So from the semantics point of view, from the perspective of how I'm going to use the word Hispanic or Latino are going to be used pretty much the same. For all intents and purposes, we're going to interchange those two definitions. And I know and I understand that some people will say, well, they're not the same. Hispanic means a person who speaks Spanish as a native language, and Latino is somebody from Latin America. Well, it ends up being that Hispanic people are also Spanish people from Spain and Europe, and they may not share these same characteristics that I'm going to share with you, or they may. And also, if we say Latin American, Brazilian people or people from Curacao, they don't speak Spanish. They speak Portuguese in case of Brazilian people, and Curacao people speak something that is very similar to Dutch. So it's very important that what we want to do here is to show you that most of the people that are Spanish-speaking who live from Mexico down shares very similar characteristics, but they all have their own significant differences as well. And so to help you out, kind of distinguish a few of the things, I'm going to go through these slides to allow you to learn more about those things. And one of my favorite people to quote is Mark Twain. He basically used to say all generalizations are false, including this one. So including these slides that we're going to follow through, take it with a grain of salt. They may be false for you as well. So I hope that you find this educational and beneficial. So yeah, every patient is different. So my objectives that I have placed here for you is first of all, I want you to be able to distinguish kind of like the behavioral pattern in the medical field of Latino patients. And there's a big distinction between a Latino patient who is in the verge of dying compared to somebody who's going in for either sutures or a broken bone. The behavior may be enormously different. And so what I want to prove to you today is that Latinos, particularly when their life is in danger, they behave as a group. And that's one thing that in the United States is less commonly seen. You will see Hispanic patients coming in with a whole bunch of people. And in the United States, people who are born in the U.S. usually come in by themselves or mostly with one person. The other expectations is that I want you to learn to adapt to those new expectations that Latino population have about their doctors. And also recognize that in some instances, the expectations that they have are negative for you, but you can take advantage of that and you can make it work for yourself. So, and the last thing is that exactly what Mark Twain said. So we try to generalize, but sometimes it doesn't apply and we end up having something totally different. So I promise that this lecture is about Hispanic patients and management in cancer. But I want to bring up an example because this example actually is going to help you relate to what happens in real life to Latinos and to myself. So before coming into fellowship, I saved a whole bunch of money and making sure that if anything were to happen, I have enough salary to survive any possible big issues. And so one of the things I did, because I love my car, it's a 2015 BMW. I promise I'm not rich, so it's just a 2015. What I did is I decided, okay, maybe I need to buy car insurance, like an extended insurance that repairs the car, because I won't have time to fix the car if I had to fix something. And also, I don't want to unload a whole bunch of money if I have to repair the car. So the timing chain basically ends up having problems. The car starts making noises. I'm getting all nervous about the car. I know that the noises sound very much timing because it starts losing power intermittently. It sounds like a rattling machine. It's not the smooth kind of self it used to be. So I reluctantly went to the BMW repair place, and they said, "Yep, you have to replace the timing chain." And that big, huge picture is what you see is a timing chain. That little white sort of piece of plastic that looks like plastic, and that big chain connects the pistons to the valves up above. And so the key issue here is that for the mechanic to repair that, he needs to go from above and below to remove the timing chain and to actually repair the whole thing. So it takes about a decent 12 hours for a good mechanic to reach that point. So I call immediately the insurance company because obviously once you are dealing with an insurance company, it makes you very nervous. I'm not really sure if they're going to help me cover for this, but they should because it's part of the repair program. So they say to me, "Well, I don't know if we're going to replace and pay for the repairs because we need to see the piece." And so I call back the mechanic. The mechanic says, hey, for me to tear this down, it's going to take me 14 hours. And if the company doesn't cover you, you're going to end up paying for the whole 14 hours of labor. And might as well at that point just replace the whole thing because it's going to be very expensive. So they told me that my car is going to need a timing chain repair, that I have to replace it, or in my head, I was thinking I need to drive the car until it dies, or I need to buy a new car. And so in the next slide, you're going to choose one of these three options, but I want to give you some more details. So in option A, I can gamble and go to get it repaired, submit the repairs to the insurance company, and hopefully they will repair the car. And then I will be ending probably $5,000 after the repair if I sell the car. Or versus I drive the car until it dies and then I get nothing for the car and I just have to sort of like send it away. And I have no idea how long it will last, and it may be that it lasts for a month or a year and I end up having to spend a lot of money. And last, I would basically have to decide whether or not I have to buy a new car, and that would be at least spending $25,000 in a brand new car. And yeah, there may be some return value for the car in the next 3 years, but that would basically put an enormous strain on my family's financial. So I wanted to be as very careful as possible. So I ended up calling my brother, who's an engineer, my dad, who's an economist and does a lot of math. Everybody was giving me their ideas. So in this next slide, is that the answers?
So far, but there'll be more.
So there's 33%. Oh, they're coming.
Yeah. So which option would you choose from those that Dr. Pena has set out? The A, repair and replace and gamble, or the B, drive the car until it dies, or C, buy a newer car? If we were talking about Subarus, we'd be talking about head gaskets instead of timing chains.
Exactly. Yes. Is that the final skinny answer? So I guess everybody, or the majority of people, chose repair and replace. Perfect. We shall see in the near future. So if you follow my conversation here, you'll see what I did after this. So putting the car a little bit more into perspective, the car example actually does very well for what we're going to talk about. So here's a picture on the right side. The gentleman right there on the bottom right-hand side with glasses is me smiling. On the left upper part of that picture, there is a man whose name is Fausto. He's my uncle who passed away of cancer. He's wearing a white cap and a white shirt. My cousin is on the front, and a whole bunch of other people on the right-hand side that you can't see because the picture can't go that far. But I can tell you that you would really need a big panoramic picture to take a picture of the entire family that was there. And this is one of the qualities of being an Ecuadorian, being from Latin America, is that the family is usually enormous and a lot of people live in the same place. Fausto was diagnosed of cancer. He actually, I grew up with him, and he was sort of like the go-to person to make decisions for anything. Fausto was a mechanical engineer. He was brilliant. He was a person who was very self-critical. He was critical of the situation. So he was the person that you would like to talk about anything and everything, and he would come up with brilliant ideas. He was always disappointed that I became a doctor and not an engineer, and actually kind of made fun of me that people who are not engineers, they're not that smart. So we would always be like, bantering around with some kind of jokes about doctors and engineers. And on the left-hand side, you see a patient who is deep in the rainforest in Ecuador, really close to the Amazon. For privacy purposes, that is not the real patient, but it's a similar patient. This patient lives in the deep part of the jungle, and he knows very well how to handle himself in the jungle. Has very little exposure to education, so he barely knows how to read, barely knows how to write, barely knows how to count, and I can be very certain that if I were to live in his situation, I would die very quickly, bitten by 1,000 mosquitoes, and then just die because I would not be able to handle all the things that he would have to handle. So this man also was diagnosed of bladder cancer, and we will see a little bit of differences between Fausto and the man from the Waorani tribe. So Fausto was a very important person in my life since I was a child, and then he lived with me here in the United States for about 8 to 10 years. 6 of those years, he battled cancer. He went back at the beginning to Ecuador to get his treatments, but then he came back here, and I helped him out arrange to get his cancer treated here, and he survived about 6 more years, which it would have been totally different had he stayed in Ecuador, and if he had bladder cancer, he would have not survived more than a year or so. Fausto and I rebuilt our deck in Utah, and you can see on the right-hand side there's a picture of a beam and a column that basically the column is bearing itself into the beam. So the deck was falling apart. We bought this house to basically repair it, both of us. And Fausto helped me do the calculations and all that stuff. So as a matter of fact, when I took my master's in science in clinical research, I took calculus, and Fausto would do calculus with me. And it was very interesting because he would smack my head when I would get it wrong, and he would say, "Yeah, that's why you get it wrong, because you're a doctor and not an engineer." He was kind of disappointed about that. But at the end of the day, he also liked it that I was a doctor, I guess, because he lived with me. Anyway, so in this situation, Mr. Q, we're going to call him Mr. Q, the Waorani tribe person who lives in the jungle, has the same cancer. Fausto has the same cancer. The Mr. Q has a very low level of education. Fausto has an extreme high level of education. He's an electronic engineer. He used to be a professor at the university. He's very well respected in society. He is very well respected amongst family. He is just what you would say extremely the high level smart person. And it's not that this is not about a conversation that Mr. Q was not intelligent, because if we put Fausto in the jungle, he probably would not survive. So it's just a different type of intelligence, right? But what I want to say is that Fausto was able to critically think and decide for himself very easily during my entire trajectory of living with him. I would always be able to see him making decisions. But what's interesting is that when I bonded with Mr. Q as a friend and as a learning doctor, they both actually told me the same exact answer when we were talking about the management of bladder cancer. They both responded to me, "I don't know what to do. You tell me. You know what's best for me." And so regardless of what Fausto believed or Mr. Q believed, what the level of education, they both had exactly the same answer. And so to make matters worse, physicians in general, we like people to take an active role in making decisions. Why? Because we see improvement on healthcare outcomes. We see that patients are engaged. They follow the things that we tell them. They do better, and we all hate failure, so we all avoid the patients that, or at least most of us would like to have patients that are more involved. They're very good at detecting early diseases, and they actually, if you have a complication, they come in earlier because they want to be part of it. You also save money because they're not in the emergency department with complications. And also, your Press Ganey scores are better because, of course, they're happy that you are involving them, you're teaching them, you're telling them how it works, and then you're telling them the options, and they're making the decisions. And what's very obvious is in the medical literature, which is basically literature proposed mostly by developed countries, is that health literacy and education and level of education is actually closely related to the ability of the patient to participate with shared decision making. So those are things that apply very well for people who were born in the United States. But as I shown you earlier, Fausto and Mr. Q being completely different from different societies, but in different levels of education, they both kind of were not making a decision in their health care. They wanted me to tell them what to do. So then you encounter the phrase of shared decision making. It's not until the 1980s that people start describing really what shared decision making is. Actually, some people, brilliant doctors, would understand that would be a better way, but it was sort of like a hunch, and then it became more like a thing that was starting to get measured. And in the 1990s is when actually medical schools started applying this sort of like approach that we should involve patients in medical decisions. And so the next slide, we are going to show you a little video. So what I wanted to let you know with this video, I promise you didn't have to bring popcorn and to watch the movie, but what I'm trying to tell you is that just like when we started working with shared decision making, we went through medical schools, fellowships, residents, making them learn that the effort should be placed on making sure that the patient understands what's happening, learns what's happening, then sees the options, and then makes a decision. And it's a sort of like a circle that you have to continue making it go round and round every time you have a visit. That is kind of like the strategy that we all use, including me. And I certainly don't frown upon that. I actually support continuing to try shared decision making by all means. And so if you are going very aggressively with shared decision making, what I'm going to try to prove to you today is that actually in Latino population, you may end up losing the caboose of the train because you actually went through it and you were not aware that the patient did not want to go through that. And so I'm going to show you some examples as well, but there's this slide, actually the one that says medicine a la carte, is basically actually something that came out of the New England Journal. I think it was like in the early 2000s, if I'm not mistaken. And basically it kind of talks about, if you read the article, it talks about how important it is to go through shared decision making and how important it is to make patients actually follow that. And people in general, like I said, we want people to follow that because it gives us better outcomes. So here I go with another case. This is actually a true case. This is a lady who's 75 years old, has history of ovarian cancer. She actually moved 25 years ago from Mexico to the United States. She does speak English and she can understand well what's happening. Of course, she has an accent just like I do, but she does well. She does have metastatic disease and has gone through multiple lines of therapy. Palliative care had been consulted for an entire 3 weeks. And the patient is having trouble kind of making decisions. The oncology team is interested in in making her be hospice because they think it's just now sort of like a waste of time, and not because, but a waste of effort more than anything else, in putting her into more discomfort regardless of what we would do. She really doesn't know what to do, and the family wants her to get more therapy. So, as I told you, Hispanic people like to come in a very large group, so everybody in the family were saying one thing or another to her, and she was like totally frozen. She was in the hospital for many, many days, actually weeks, and I'll show you what happened to her. It's very interesting how decision-making changed from one thing to another very frequently. And the next part is we have another question for you, and it's assuming that if you think like the oncology team, and you would and you really want to help her make a decision, what do you think is the best next step for this patient? So, do you give her another line of therapy and follow what the family members say? Do you send her to hospice? Do you give her the clinical trial, a phase 1 clinical trial that was available at that time? Do you wait for the family to make the decision for her? Then they need to be in agreement first. Or do you wait for the patient to make decisions? When she was not waiting, she was still waiting to figure out what she wanted to do. And it was already 3 weeks of totally not able to make a decision. Palliative care would talk to her, give her information. They made drawings. Everybody, they came in with pamphlets. They brought in the hospice care people. They brought in the research people, and the lady was not making decisions. And so, for this question, there's really no right answer because the right answer is really not there. But what I wanted to show you is that that's how people felt during the management of this case. And so this is her decision-making kind of during the first 3 weeks, or during the last 3 weeks of her hospital stay. First she said, okay, I'm going to go third-line therapy. As soon as they were telling her, the oncology team was telling her, okay, well, if you go third-line therapy, and this is not a talk about ovarian cancer, just FYI, but the oncology team would say, okay, if you go through the third line of therapy, you are going to get such and such and such side effects. And everybody would get ready for the third line therapy, and immediately she would say on the next morning, no, okay, I don't want it anymore. I'm going to go hospice. And so forth and so on. And then the family members would come in and say, hey, hospice, no hospice. We want either clinical trial or third line therapy. And she would go into a clinical trial. And we did this basically back and forth for 3 weeks. When I kind of got into that case, it was at the end of the 3 weeks. And so a lot of it is obviously already what has passed helped her make decisions. But in some way, I also helped her make a decision because I understood where she came from. And so at the third week, she kind of stopped we made a hard stop with her. I had the conversation at that time with the oncology team that this is not the regular patient who should be making decisions in this way. And we talked about how we should approach her. And so we said, stop, let's give you different options. And so before we go and discuss a little bit more about exactly what we did for that patient, I want you to know about what are the disadvantages of making patients become active participants in their role in their decision-making, in their healthcare decision-making. So actually this has been already, there are several articles publishing this, that there are several people, particularly Latino culture in general, that prefer to be a passive patient, meaning they prefer for you to make decisions rather than them making a decision. They don't feel good enough to make that decision. And so what happens is that when you force a patient, when you say you have option A, option B, option C, it's that at the end of the day, they feel pressure and they end up actually aligning with a choice that they never wanted. Or you end up, like in the case that we just talked about, you end up having multiple resources applied to her. And at the end of the day, you end up having 3 weeks of somebody who stays in the hospital. And we don't even know if actually staying for that long has any repercussions in health. Like, does it have an increased risk for nosocomial infections? Does it have any increased risk of medical errors that can cause trouble? So we don't know that, right? And at the end of the day, they end up not trusting you because, of course, you're supposed to be the one who makes the decision, but since you're not making the decision, you as a doctor not making a decision, you're making her make that decision. She doesn't trust you. She thinks that you don't know what to do. And this leads me to the first phrase that I like to use, which is basically decision paralysis. Decision paralysis is actually a real thing. Decision paralysis happens very frequently when patients do not have the ability to make decisions, not because they're incapacitated, but because emotionally they're blocked. And so decision paralysis does happen in Latino patients, in that every time I've had a Latino patient who I see that does not make a decision, I kind of can tell because I've been exposed to this sort of like experience-wise, and my experience may be very biased, but I kind of can distinguish because I've seen it before. So in reality, if we measure things, if we try to measure things, if we try to measure how much Hispanic patients like to have a passive role versus American-born patients, Hispanic patients that are born in America, and then American people who have no Latino inheritance, we can see that in several of the studies, actually, patients who are in Latin America prefer their doctor to make decisions for them. So that means that the patients in general trust more than the doctor than themselves to make a decision in healthcare. Just like Fausto, when he said to me, "Why are you asking me? You know this better than I do." And so just like the little girl, and that's my daughter right there on the right lower corner, just like that little girl who feels like she's a superhero and can beat anybody around, they believe, and not everybody, of course, but they believe that you are the superhero who knows what to do next. So why should they make that decision? And so that's very key, and that some of the research that I'm posting up there shows that. What's interesting in that research is also that patients who are born in the United States who have family members who are Latino, who were migrants at the beginning, they actually behave more like people born in America. Because in America, you have the ability to make choices. That is the American way of thinking. In general, Americans believe that we should be allowed to make decisions for ourselves. We should have the freedom to choose. And in what's happening here is that does not necessarily apply in the Hispanic population. Okay. So this paper was actually very interesting. This is a paper that I encountered while I was doing the research before giving this talk. And what's interesting is that shared decision making, actually, even if you're dealing with Latinos, it is an active and evolving process. It's not a static thing. So it is very frequent that the first visit, Latino patients will want to know what you want to do. But what they actually have shown is that the further along they go, the more comfortable they get, and then they participate more in their care. So knowing this, recognizing this is very important because it allows you to move faster and better with your patient. So what's important about this in what I encountered in the medical literature is that almost all, if not everybody who published anything about this, is that they say, look, we need to train better physicians how to adapt to shared decision making, because there is a lot of people that have the passive decision making, and that's not wrong. It's just a different way of doing things. And so instead of forcing them to do stuff or decide, we move away from that and we adapt to their requirements. Also, the truth is that most of the study is done in developed countries, is not done in Latino population. And so the few things that we have available, it's interesting that several of those studies show that most of the people, and not all of them obviously, but most of the people that do have this passive way of thinking is actually Latino. And so it's a dynamic process. And to make it a little bit more interesting, there's a study that actually looked at how well patients felt with people from their same ethnicity versus any other ethnicity. So what they did is they tried to see, okay, well, let's pair physicians by age and by their language and by their race, and see what happens. And basically what's interesting is this is a research done from the University of Utah, actually, and it carried about 9,600 patients. So it was a pretty big study. But what they did figure out is that what's interesting is that the more the physician looks and comes from the patient's ethnicity, the better the patient's response to the questionnaire of, did you get explained things better? Did you feel like you were making decisions for yourself? Did you feel like the doctor was making decisions for themselves? So you got a better chance of getting better Press-Ganey scores, if you like Press-Ganey, if you assign doctors who have the same ethnicity compared to those who are, randomly picked. So it does speak for some level of, maybe in your practice you want to consider putting patients with Hispanic patients with Hispanic doctors if that's available. Obviously, it's not something that can be done necessarily all over, but it actually does speak for that maybe it helps you out with patient care. The other thing that I actually encountered, which is one of the most vulnerable groups in society, the LGBTQ group. So when I went through this literature, I was looking at, I encountered the research done on LGBTQ migrants. And so it ends up being that, so the Williams Institute is like a school of law, but it dedicates itself to actually measure disparities in people, particularly people of either a low socioeconomic status or migrants or things like that. It ends up being that 71% of the people that migrate to the United States is actually LGBTQ who come from Latin America. And so in one of the thought processes is reading a few of the opinion articles is that LGBTQ people in America also feel that they're segregated. And so they feel like if they cross the border and come into the United States, they will be more accepted because this is the land of acceptance and opportunity. So I wanted to share this because it would be extremely likely, based on that information, that you are going to encounter LGBTQ people that are not going to tell you that they're LGBTQ. And realizing that those people are LGBTQ may need an extra effort from us to try to help them maintain their health So it may mean the extra phone call to see how they're doing, or they may mean the extra visit to make sure that they're complying with medicines. Now we're going to go for our next video. Yeah, so I showed that video. I mean, this guy is Greek. I don't know if you've ever watched My Big Fat Greek Wedding, but it's a funny video in the sense that that's what's happening to my kids right now. So after Fausto was diagnosed with cancer, my parents also came to live with me. And so my children, with their broken Spanish, kind of guide my parents everywhere. And my mother has dementia. And so there's sometimes where they chase around my mother through the neighborhood trying to bring her back because she's running away. And so what I'm trying to say is we come in herds. We come in, our families usually have to be together. It's a thing. So Latinos want to be in families and like making decisions as a family, as a whole team. And there's nothing bad with that, and there's nothing right with that. And it is a distinction from American society where it's more sort of like an individual type of society, but each thing has its advantages and disadvantages, and there is nothing wrong with one way or the other. What I want to share with you is that we are most of the time coming with family members into your clinic, trying to figure out what to do next. So actually, you should feel uncomfortable if a person is Hispanic who has migrated to the United States, and you see him in your clinic, and you see that that patient is alone, and this is the first time he's seeing you or she is seeing you. That should raise some red flags, because most of the time, patients will come in with family members at their side. So, as the slide points out, we believe that there's an obligation with our parents. We believe that that we should be together. And as a matter of fact, there's no secrets between family members. You even know that you've made a mistake before. Your mother knows you made a mistake before you make one, because people are already told. And so, and the other thing is repeating again, once again, the culture is to have a physician who makes decisions for the family. So that is key to understand, that you, at a certain point, are going to be making decisions for them. And there's nothing wrong with that. So the last thing to say about this, which comes from that article, Family-Based Psychological Interventions in the Latino Population, is that almost always when patients come in as a group, there's always that person who makes decisions for the patient. And that is your key ally. That person, just like for Fausto or my father, I was the person who was in front of them at all times, talking to doctors and nurses and people. I was the key person to make decisions with. So you want to have that person with them at all times. If not, make sure that you communicate with that person who's at the front of making decisions for that person. So we come into the last part of the conversation, which is how do I recognize that a person or a patient is a passive decision maker, and how to adapt to that. And so we recognize them by listening to what they say. So when they tell you, hey, I have no idea what to do, so that's strike one. And then they say, I don't even know what the best option is. That's strike two. You've already gone through the menu of things that you can give him. You know, I can give you MVAC versus gemcitabine and cisplatin, and you're giving them all the information. And they're still not making a decision. Well, that's strike two. And then they say to you, why don't you tell me what you would do? Strike three. Okay, now it's clear that this person is a passive decision maker. And so before you slow him down even more by trying to explain even more, by providing more, stop. No more menus. And this is the new term I'm going to introduce here. This is not in the literature. I just made this up because it's very key. Stop. No more menus. Meaning combo meal number 1 being MVAC, combo meal number 2 being gemcitabine for bladder cancer, combo meal number 3, total resection, or number 4, whatever. Stop. You basically are going to have to recognize that that person is not going to make a decision. And you're going to have to make a decision based on, or shorten the options so they can make a decision between 2 and at most 3, and that would be pushing it. So shortening explanations, using no medical terms is key. And honestly, and most frequently, what I do with them is I do ask them, so do you want to know what I would do if I was in your shoes? And if they respond to that question, yes, and you answer that question, it is very likely that they will make the decision that you have proposed. So, too much information is overwhelming, and if they are passive decision makers, they are people that will make decisions and follow you to the T. So another case that we can talk about, this is a 61-year-old female. She's from Mexico. She doesn't speak English. She was diagnosed with CMML and then transformed into AML. She had a haploidentical transplant, and 30 days during her transplant, she develops graft failure. And this is not a talk about management of graft failure or anything like that, but it's a talk about how she views things. And she refuses to get a bone marrow biopsy. The team and everybody is so concerned. Why is she failing her graft? We want a bone marrow biopsy. She says, no, I don't want to go to hospice. But she can't move forward with the bone marrow biopsy because she's already gone through conditioning and she's like done with feeling more pain or discomfort. The son, who's the donor, is like crazy, crying right at bedside because he wants her to get everything done. They've already done everything as they could. And more testing is not going to be as precise as the bone marrow biopsy, and there's still a lot of more pending to really see how we can help this lady overcome the primary graft failure. So the BMT is basically thinking, primary graft failure, we need a bone marrow biopsy now. If we don't have a bone marrow biopsy, we cannot move forward. Obviously, you cannot force her to have a bone marrow biopsy, and the son is pressuring you aggressively to get the bone marrow biopsy done, either by sedating her, and he'll sign the form. But the patient is telling you, I don't want any invasive testing, but she wants to continue giving the transplant a chance. She just doesn't want more testing. So what would you do in that case where the patient, if you were the BMT attending, and you are going to decide between ignoring the son and basically doing what the patients ask? Are you going to appoint a new guardian because the son, who's the POA, is not making decisions? Are you going to make her DNR and just send her to hospice? Are you going to perform the bone marrow biopsy under sedation and have the son consent? Or is no decision an option? No decision is not an option. And we will talk about that in a little bit.
Right.
55. Almost there.
Just want to say thank you to everyone for so quickly responding to
Yes.
these polls.
Thank you. So no decisions, no more menus. Remember what I said. So stop the menus. At that point, when I came in, I basically spoke to her. So it's important to know that the families are very critical to make decisions for patients. But at that point, we basically decided that no decision is not an option. So in the most kind and compassionate way, we said to her, okay, if we cannot get the bone marrow biopsy, then we're going to let you go home tomorrow. We advise for you to consider hospice care because you're going to be very uncomfortable once you go home. We will have a lot of trouble trying to help you out. And as I said, this is not management of primary graft failure. So you can argue with me, oh yeah, but you could have done this and that. And yes, true. But so we knew we needed the biopsy, and so we basically cornered her into a simple decision. No biopsy, we need to let you go home. And so she ended up making a decision. Made a decision that yes, she's going to go through the biopsy because she wanted to stay and keep on trying. So what I was trying to show you with this example is that no more menus, no more explanations. So no decision is not an option is a very important thing to consider in the Hispanic population. So you're not threatening her. You're not saying, I don't like you. You're basically offering her the only option that you have, which is, I cannot give you more care if I don't have that information. And you're not required to give her more care if you don't have enough information. Legally speaking, there is nothing wrong with that. So I'm coming to the end of the conversation. So the take-home points here is that, number one, I want you to realize that first-generation Hispanics behave very similar to the American population. They're aware of their decision-making, and they're aware that they can make decisions. And that does not apply necessarily to migrants who come from abroad as the first time. So migrants have more of a passive role. Recognize quickly that they are in a passive role and adjust to that. Take that to your advantage. Don't force it in. Shared decision making is not a static process. It's actually a thing that evolves and makes people make decisions better as they go through. Be aware that no decision is not an option and that you can actually corner patients into making a decision by showing them that there's no decision is not an option. There is not a choice. It's not a multiple choice that you choose. And so since there's not an answer there, they either have to choose one. Just like when you talk to a patient who you're making a DNR or addressing code status, if the patient decides, you say, hey, this option number one is I give you everything, you get intubated, you do chest compressions and things like that. Option number two is you give him everything that you can, but you don't do chest compressions or intubation. And option number three is hospice care. I know that there's more options, but what I'm trying to say here is you offer them those three options. And if they don't make a decision, they're still in option one. So patients not making decisions can be already in a decision. So if your patient with the talk about code status does not make a decision, when the patient has a code, your job is to code them because they didn't make a decision. So now you assume that they're a full code. So the same way with Hispanic people. Corner them into making a decision. So Hispanic doctors tend to do a better job. This is actually a question mark. So maybe if you are in a practice where you can allow doctors who are Hispanic to see Hispanic patients, maybe better. I don't know that, but that's a thing there. Children and family make decisions for the patients, and that's very key to understand. And they're your resource. They're actually somebody that you want to keep in close contact. We talked about that we need to recognize passive decision making and that we need to adapt to that and that they are an advantageous group of people for physicians. Recognize when the family decides for the patient, and that's okay too. One of the interesting things here is particularly here in North Carolina, which I did not encounter in Utah, is that, for example, for my dad, I almost always have to ask my dad to be on the phone to ask permission to go through information, even though I've signed all the forms. And then the forms come back saying, well, you need to notarize it. And then you send them notarized. And I don't think that patients in general want to be notarizing things, particularly if they're Hispanic and they're like very uncomfortable with the thought process that being in healthcare may actually cause them trouble with immigration or things like that. So it is very key to know that sometimes it's better to just adapt to the patient and let the family member make decisions. So when family members, like in the case that we talked about, that the lady with cancer that did not want to make decisions, did not want to go to hospice, did not want to, and the son and daughter were trying to make different decisions for her. Stop. No more menus. That's it. You are going to corner them into a decision, and that's it. So remember the stop, no more menus. Remember that no decision, no choice. So by all means, I do endorse the fact that we should continue to apply shared decision making at all costs, but with the caveat that we need to adapt to the patient who does not make decisions. So back to the car momentarily. So here the example is perfect because I told you that I was going to tell you that it has some relevance. The Hispanic patient is me, and that's the owner of the car. The car is the cancer with the issue. And then the way to repair things is the fixing options. And what I did is I completely froze for a week because I did not know what was best. I called my family members. Everybody was telling me something different. I did choose to repair the car and ended up paying about $5,000. The insurance company said, we're not going to cover everything. So basically that was like just a waste of money. And so I want to bring you to other references in recommended reading. I'm a strong believer in textbooks. I obviously did not train in the United States for medical school, so we actually used to go through textbooks a lot. And one of the advantages of having textbooks is that it's just there's a whole bunch of summary of things that that are not narrowed down as in a review paper in a New England or something like that. So these two textbooks are actually from similar authors, and they're very good at kind of explaining how cancer goes around for Latino population from the perspective of the emotional view, but also from the perspective of the genetics-wise. They question how we use genetic testing in the Hispanics, in the Hispanic population, and we use it similarly to other populations, and they have very good information about how that may be not tailored precisely for the Hispanic population. So those are very good recommended reading material. And then there's also the material that you can listen in the Yale Medicine podcasts. Their website is actually very user-friendly, and they have a lot of discussion about Latinos and management of Hispanic patients with cancer and other diseases that are actually very interesting to listen to.
All right. Dr. Pena, this has been fascinating. I've definitely learned a lot. I know our audience has as well. We had a large audience, at least 106 for today's presentation. Let's see. There should be a slide coming up. Let me see if I can get that to show up. If not, I'll just go, yeah, it's having a little struggle here. So if it doesn't show up, I'll just go ahead and read it. So the first question is, when do you recommend or advise patients and caregivers are educated on what palliative care and hospice are? I see oftentimes that they're not familiar with these concepts.
True. So one of the things that happened in Ecuador, and I am not aware of what's happening in other countries, but when I was a resident there, palliative care was viewed as, it's like the place where you go and die and you're going to be miserable. So almost never a patient would accept to go palliative care.
Gotcha.
And that was like sort of like the fear of being miserable while dying.
Yeah.
So patients tend to choose, and most commonly because the family is so close, patients tend to choose to be with the family. So now trying to use that information in favor of the patient in this circumstance, which is what I think the question is getting to, is that offering hospice care at home as your priority to tell patients, hey, we can give hospice care, explaining how the benefits of hospice has even shown in several people with terminal cancer. If we offer that as a possibility and saying you can do this at home and fighting for that, I think that would be an option that people would take more and be more open to.
Okay, thank you. We'll take one more question because I know that our audience will need to leave. But how many times has your passive patient delegated to you decision backfired on you?
So it's interesting that, so I'm going to give you a little anecdote, and this is true story. I was in Ecuador being a last year medical student. We were rotating through the OBGYN hospital. And the surgeons basically would do C-sections all the time. And there was this motto that every person who had more than 5 kids, they would basically tubal ligate the patients without even consenting them. Just basically, yeah. Oh. And I don't endorse this. By all means, I don't endorse this. But and you would hear all these anecdotes around this doctors making decisions for patients because, the lady would come next year having another C-section after the 5th child. The doctor was concerned, am I going to have to be dealing with somebody who blows through that uterus, and I don't want to deal with that, so I'm just going to tubal ligate her. And I'm not defending this, but what I'm trying to say is rarely you see the patient who, or if ever we see patients actually suing the doctor for things like this. So if you go back here, I have not had the experience of making decisions getting backfired on me because in general I can recognize the patient who is very passive at making decisions, and most of them are very appreciative. And if you're concerned about that you could be sued or things like that, then you can say in your note or how you're talking to them, you can say, hey, she made the decision to allow me to do the choice for her.
Gotcha.
And that is an acceptable approach.
And having that clarity.
Right.
Right. All right. And I apologize. We don't. We do have more questions, but we need to go ahead and move forward. May I borrow the keyboard back?
Yes.
Oh no, that's fine. So quickly, just want to say that that we want to thank North Carolina, the funding for the University Cancer Research Fund, the UNC Lineberger Comprehensive Cancer Center, the team, Veni Obore, John Powell, Oliver Marth, Andrew Dodgson, Patrick Muscarella, and Kim Riddick for all the hard work that they do on each and every one of these lectures.